welcome to my channel. Today I'll be talking about angina and the use of nitrate therapy. As always, please don't forget to like, subscribe and share. I have split the video into various sections, so feel free to skip to the section that's best for you. I've sectioned the video into introduction to angina, purpose of anti-anginal drugs, classification of anti-anginal therapy, nitrate therapy and types of angina. So first of all, I'll talk about atherosclerosis and its relevance to the heart. This is the buildup of fats, cholesterol and other substances in and on the arterial walls, which is the leading cause of angina. This itself can restrict the blood flow to the heart. The main point of concern are the arteries on the heart, which are also known as the coronary arteries. I have drawn this diagram over here to explain how the buildup of substances can lead to complications of the arteries. So here we have a normal artery, and here we have an artery that has deposits, but it's not clinically having an effect on the patient. Here we have atherosclerotic plaques that could possibly cause signs of stable angina. If the plaque gets larger and ruptures the artery, then the signs could become more clinically significant, leading to unstable angina, which could then lead to myocardial infarction. So important consequences of coronary atherosclerosis include angina, which we are going to talk about today, and myocardial infarction due to the complete occlusion of the arteries. I will do another video on this, so please look out for that. Angina occurs when the oxygen supply to the heart is not enough for its needs. In a healthy heart, there is little resistance to blood flow in the epicardial vessels. When atherosclerotic plaques are present, then the blood flow is obstructed, but the process of autoregulation can usually compensate, but only to a certain degree. Anginal pain usually has some sort of characteristic distribution in the chest, arm and neck area. Angina pectoris is generally the medical term for chest pain or discomfort due to coronary heart disease. It occurs when the heart muscle itself doesn't get much blood as it needs. This usually happens because one or more of the heart's arteries is narrowed or blocked, like how we mentioned earlier, which is also known as ischemia. The pain is due to the release of adenosine, bradykinin and other molecules that are able to stimulate the sympathetic nerves. So now that we have talked about the possible leading cause of angina, we can look into therapeutics that can help alleviate the condition. So anti-anginal drugs are those that either increase the supply of oxygen and nutrients or reduce the demand for these. So drugs that reduce myocardial oxygen demand are commonly used to prevent and treat episodes of ischemic pain associated with the stable angina. So some of the drugs, how they would work is that they would reduce the heart rate, which is also known as having a decreased chronotropic effect, reduce the contractility, which is also known as a decrease in inotropic effect, reducing the preload and afterload of the heart. So different classifications of drugs that can potentially be indicated include vasodilators such as nitrates, So here you've got short-acting and long-acting nitroglycerin and isosorbide mononitrate. We will focus on these a little later on. So the next classification of drugs are calcium channel blockers such as amlodipine, diltiazem and verapamil. And the next classification of drugs are antithrombotic agents. So here you've got anticoagulants such as heparin and warfarin, and you've got antiplatelets such as aspirin and clopidogrel. These reduce the aggregation of platelets that adhere to one another. You also have another cardio-inhibitory drug as well as calcium channel blockers, which are beta blockers. So you've got atenolol or bisoprolol that can be used. The fifth classification is ranolazine, which reduces the calcium overload and left ventricular diastolic tension. It's also known to be an add-on therapy which produces small reductions in the HbA1c levels in diabetic patients. So it's useful in diabetic patients. You have metabotropic drugs such as dipyridamole. These can inhibit blood clot formation when given chronically, and they can also cause dilation of the blood vessels when usually it's given at high doses over a short period of time. And the final classification is ivabradine. This regulates the pacemaker activity in the SA node, but it's usually for patients that cannot tolerate beta blockers. Okay, so now we'll focus a little more on organic nitrates. These are very potent coronary vasodilators. So all organic nitrates kind of share the same action but only differ in their time course. The direct dilator effect on the coronary arteries reduces the spasms of the artery itself. So coronary flow is thereby increased as a result of the coronary vasodilation. And myocardial oxygen consumption is reduced because of the reductions in both the preload and the afterload of the heart. So we'll talk about the mechanism of action of the organic nitrates. So the major action is direct, non-specific smooth muscle relaxation. So organic nitrates are metabolized with the release of nitric oxide. So nitroglycerin, as an example, is converted into the nitric oxide. This then activates the enzyme guanylate cyclase. Guanylate cyclase then stimulates cyclic GMP, which then dephosphorylates the cells of the smooth muscle and releases the calcium ions. The release of calcium ions then results in the relaxation of the smooth muscle cells and thereby vasodilation. So its main site of action is the peripheral vascular system and the coronary blood vessels. So it lowers the systolic blood pressure and dilates systemic veins, reducing the wall tension of the heart itself and its need of oxygen. So like how we said, they differ in the time course. So we'll talk about short-acting nitrates. An example of this is glyceryl trinitrate. This is commonly used for the acute treatment of angina. It's available in different formulations. So you've got the sublingual, transdermal and injection form. So the sublingual is the most effective in providing rapid symptomatic relief of angina, but it usually only lasts around 30 minutes. The good thing about this is that it bypasses the first pass metabolism, hence why it's having its short acting property. So the only caution of this is patients with hypothyroidism. Side effects include postural hypotension, throbbing headache, and tachycardia. These are some of the common side effects. The aerosols is usually sprayed 1 to 2 times under the tongue. It's well absorbed from the mouth. It can be taken under the tongue or as a sublingual aerosol spray. It's ineffective if it's swallowed due to the first pass metabolism degrading the chemical itself. So effective duration of action, like how we mentioned, is around 30 minutes, and it's rapidly inactivated by hepatic metabolism. Now we'll talk a little on long-acting nitrates, and examples of these are isosorbide mononitrate and isosorbide dinitrate. These are usually given for prophylactic treatment of angina. They're given if symptoms persist after a beta blocker dose is maximized for the patient. So they are longer acting than glycerol trinitrate. They are usually absorbed and metabolized much more slowly, but has similar pharmacological actions. They are swallowed rather than taken sublingually, and the usual dose is twice a day for prophylaxis and avoidance of tolerance. The half-life is around 5 to 6 hours, and they're metabolized by the liver, with most of the drug excreted via the urine. The patches are available as well. They are slowly released for a much more prolonged effect, which increases the capacity of exercise for the patient. Tolerance is one of the biggest complications for patients that take the long-acting nitrates, because many patients that are on long-acting or transdermal nitrates rapidly develop tolerance, and if tolerance is suspected during the use of patches, then they should be left off for around 12 hours. Conventional formulations of isosorbide mononitrate should not be given more than twice a day due to tolerance being developed. Some of the contraindications include hypersensitivity to nitrates itself, hypotensive conditions because it reduces the blood pressure, and finally aortic stenosis and mitral stenosis. Some of the interactions are hypotensive effects of nitrates, which are significantly enhanced by other hypotensive drugs. Now we will talk about the different types of angina. So first of all, we'll talk about stable angina. This usually results from the buildup of atherosclerotic plaques in the coronary arteries that restrict the blood flow and the supply of oxygen to the heart. It's often exacerbated by exertion and relieved by rest from the patient. Treatment involves management of acute angina pain and long-term management to prevent angina attacks and also to reduce further cardiovascular events. Symptomatic treatment is directed at reducing the work of the heart, so cardiac work, with organic nitrates and beta blockers or calcium channel blockers. So for acute attacks, it should be managed with sublingual glycerol trinitrate. This could be taken before performing strenuous activities. In terms of management, patients with stable angina should be given a beta blocker or a calcium channel blocker. If both are contraindicated, then you can have monotherapy with a long-acting nitrate, as we mentioned earlier. Treatment is usually combined with a statin, so this is to reduce any underlying atheromatous disease and prophylaxis against thrombosis, could also be used with an antiplatelet drug such as aspirin. Now we'll talk about unstable angina, which is also known as acute coronary syndrome. The most common cause is again reduced blood flow to the heart muscle due to the coronary arteries being narrowed by the fatty buildups which rupture, causing injury to the blood vessel itself. This results in blood clotting with non-occlusive thrombus, which blocks the flow of the blood to the heart itself. So unstable angina is characterized by pain that occurs with much less exertion, and it's usually at rest as well in comparison to stable angina. It's often characterized by stable angina itself, but it suddenly worsens, is kind of recurring on or prolonged angina at rest. It occurs in a similar way to myocardial infarction, but without complete occlusion of the vessel. Treatment is the same as for myocardial infarction. The aim of management is to provide supportive care and pain relief during an acute attack, and to prevent further cardiac events and death. So initial management, like how we said, is the same as myocardial infarction. So you would administer oxygen if there is evidence of hypoxia or any pulmonary edema. You would give nitrates to relieve the ischemic pain. If the sublingual GTN is not effective, then you've also got the IV or buccal route which could be given. If the pain continues, you could give an opioid analgesic such as morphine, which can be given as a slow intravenous injection. Antiemetics are sometimes also needed, such as metoclopramide. Aspirin is given for its antiplatelet effect as soon as possible. This is usually in a dose of 300 milligrams and not 75 milligrams. Beta blockers should be received, which should be continued indefinitely, and you could also provide unfractionated heparins, which could be used in patients at high risk of myocardial infarction. Long-term management, you could provide ticagrelor in combination with a low-dose aspirin for up to 12 months, as stated in the NICE guidelines, and initiation of antihypertensive treatment along with statin. The third type of angina is a variant angina. It's usually uncommon and it occurs at rest, and it's caused by spasms of the coronary artery, which is associated with the atherosclerotic plaques itself. They are treated with coronary artery vasodilators such as the nitrates that we mentioned before and calcium channel blockers. So hopefully you've enjoyed the video and you've learned something today. I do apologize for making this video slightly long. I will do another video on myocardial infarction, which should be interesting, so hopefully you could join me on that. Thank you for watching, and please do subscribe, like and comment if you haven't done so already. Thank you.